Young Nigerian Neurosurgeon Forum monthly webinar. This evening we have a big fish, very big fish. The president of our parent association, Professor Bakole, officially is our senior faculty student. It's always been around, but today we ensured is the senior faculty. This evening we'll be going through cerebral vasospasm. The presenting center is the University of Nigeria Teaching Hospital, and our moderator for this is Dr. Ogenevoke, and I want us to sit back and enjoy the beautiful presentation, and also our comment and the question to be raised and attended to at the appropriate time. Thank you very much. Dr. Inawo, over to you.
Thank you, Dr. Adegboye. Good evening, all. Good evening, our teachers, senior faculties, and everyone. I'm Inawo Ogenevoke from UITH Ilorin. As already announced, we have a topic for presentation today. I want to, before I jump the gun, I want to thank the YNF leadership for this opportunity to moderate this meeting. And so today we have a topic before us, cerebral vasospasm, to be taken by our colleagues from UNTH Enugu. The speakers we have for today are Dr. Bright Iwekela and Dr. Chubike Aka. First speaker will touch on the part of physiology and pathology, while the second speaker will speak on clinical presentation and management. Both speakers have 25 minutes each. So follow on the first speaker, starts the presentation. I trust it to be an interesting one. So Dr. Bright, over to you, please.
Thank you very much. Good evening, professors, senior colleagues, and colleagues. I'm Bright Iwekela from University of Nigeria Teaching Hospital, Neurosurgery Division. I'll be taking the physiology and pathology for this cerebral vasospasm. The outline is as shown. Cerebral vasospasm is a complex pathologic process that is among the most detrimental after effects of subarachnoid hemorrhage. The pathophysiology is complex and multifactorial, and it involves complex interplay of molecular, cellular, hemodynamic factors. And this underscores the challenge of management of cerebral vasospasm. It's been defined as a delayed, prolonged, and reversible narrowing of cerebral arteries, typically occurring day 3 to 14 after subarachnoid hemorrhage. And it can be a segmental or diffuse narrowing of the cerebral vasculature. Hence, the knowledge of the cerebral vasculature is important. So that's why I put up these clinical photographs here, which underscores the origin of the supply from internal carotid artery, then the vertebral arteries, where they come to form the circle of Willis, which is important in their distributions to different parts of the brain. So, which means
Dr.
for every focal
can't see the slides. Can we sort that out, please?
Yes, sorry. I thought it was just from my own end. So, Dr. Bright, we can't see what you are presenting. Hello, Dr. Bright.
Yes, okay.
You may need to do something about your connection.
Can it be seen?
Well, yes, but okay. Yeah, we can see it now.
Okay. Sorry. Okay, sorry about that. So, I say it's a complex pathologic process that is among the most detrimental after effects of subarachnoid hemorrhage. Now, the pathophysiology is complex and multifactorial, and there is an interplay of molecular, cellular, and hemodynamic factors, which underscores the challenge of management. Cerebral vasospasm is defined as delayed, prolonged, and reversible narrowing of cerebral arteries, typically occurring between the 3 and 14 after subarachnoid hemorrhage. It's also been found that it's rarely do not occur before 72 hours after subarachnoid hemorrhage. And the vasospasm that results can be as a segmental or diffuse narrowing of the cerebral vasculature. So the supply to the brain is from the internal carotid artery and the vertebral arteries, and the circle of Willis is an important region for which we can trace the supplies to different parts of the brain. Much of the problem with cerebral vasospasm from subarachnoid hemorrhage results from problems around the anterior cerebral artery ruptures. So when there is subarachnoid hemorrhage, we usually use the FNS, WFNS grading, or the Hunt and Hess classification. The WFNS grading, it takes into consideration the Glasgow Coma score of the patient, and is from 0 to 5, and the Hunt and Hess classification from 1 to 5, from asymptomatic to patients that are deeply comatose. There are other pathologic processes from which cerebral vasospasm can result. These include intraventricular hemorrhage from arteriovenous malformation, hemorrhagic tumors, head trauma with or without subarachnoid hemorrhage, brain surgery, hypothalamic injury, lumbar puncture infection, preeclampsia. Over 30% of patients with ruptured aneurysm develop delayed cerebral ischemia, which is an umbrella name encompassing the symptomatic vasospasm or delayed ischemic neurologic deficit. So it's important to look out for vasospasm in patients with subarachnoid hemorrhage. Early brain injury has been defined as a direct mechanical damage from the subarachnoid hemorrhage with transient increase in intracranial pressure, reduction in blood flow, apoptosis, and edema formation. This term originated in vasospasm. The concept was by Ecker in 1951, and studies have found out that 12% of pre-hospital deaths following subarachnoid hemorrhage and vasospasm, 12% account for pre-hospital deaths. Then 40% of hospitalized patients with vasospasm die within 1 month, and 1/3 of the survivors have major neurological deficits, and 1/3 of those with subarachnoid hemorrhage return to normal life. Incidence is higher among those with lower socioeconomic status. This is because they are predisposed to comorbidities for which aneurysm can result. Their attention, their hospital attention to find out what the problem is not interesting, and the cost of management is high for them. So management is a problem. So this incidence in the low socioeconomic status. Grieve and Kitchen in 2003 did a study to look at the morbidity and mortality due to cerebral vasospasm over the years. And in the 1970s, they found out that it accounted for 25 to 30%. And in the 80s, it accounted for 15 to 20% of morbidities and mortalities. And beyond the 1980s is about 5 to 10%. This reduction is due to increased or improved postoperative management and anti-vasospastic agents. Cerebral vasospasm has been divided into 2 non-reconcilable definitions of angiographic or radiologic vasospasm and symptomatic vasospasm. The delayed cerebral ischemia can be used interchangeably with delayed ischemic neurologic deficit, and symptomatic vasospasm. Symptomatic vasospasm or clinical vasospasm or delayed cerebral ischemia accounts for 20-30%, and angiographic vasospasm or radiological vasospasm accounts for 70%. For the symptomatic vasospasm, this is a delayed development of neurologic deficits. And when there is a decline of the Glasgow Coma score by at least 2 points, and maybe when there is a cerebral infarction that is unrelated to their aneurysm treatment, then traumatic vasospasm can be made. Angiographic vasospasm is arterial narrowing demonstrated on cerebral angiography, which means there is a slowing of contrast in the region. This has to be solidified by a previous or a subsequent angiogram, which means it has to show the same vessel, but one shows the normal caliber and the other shows the narrow caliber. It is said to be non-reconcilable definition because a patient can have angiographic vasospasm without symptomatic vasospasm dictated, and sometimes a patient can have symptomatic vasospasm. Shown angiographically is higher compared to those who present with symptomatic. Image of an angiogram that is done showing the region of vasospasm before the dilatation. The M1 and M2 segments indicated by the narrowed white lines can be seen. Then the after vasodilatation, you can see the dilated, the normal caliber of the vessel thereafter. This is a histologic appearance of cerebral artery in the subarachnoid space. For A, it shows the normal size of the cerebral artery. But for B, due to the contraction, constriction, the caliber is found to be reduced. The histologic appearance. So the mechanism of vasospasm, for patients with subarachnoid hemorrhage, there is blood in the subarachnoid space, and hemoglobin and its products now activate cascade of events for which the free radical reactions promote the vasoconstriction. There is a scavenging effects on the hemoglobin on nitric oxide. Then the metabolites from the arterial walls also have a vasoconstrictive effect, and perivascular nerve damage also has a vasoconstrictive effect. We take them in order. The initiating events in cerebral vasospasm is the hemoglobin and its breakdown products, which include the oxyhemoglobin, methemoglobin, iron, bilirubin, oxidative products. These accumulate around the cerebral arteries. These products trigger increase in free radical formation, which causes oxidative stress. There is increase in lipid peroxidation, which causes endothelial damage. There is endothelin-1 release, which is a potent vasoconstrictor, and nitric oxide bioavailability is reduced. Endothelin-1 binds, it has receptors, endothelin A receptor and endothelin B receptor. Endothelin A receptor is found in the vascular smooth muscle, whereas endothelin B receptors are found in the endothelium. With the bleed into the subarachnoid space, there is impairment of the binding of endothelin-1 to the endothelin B receptors. Hence, vasodilatation is affected, and there is binding of endothelin-1 to endothelin A, upregulating the vasoconstriction that is occurring. And it's been found from modified Fisher scale that there's a relationship between the amount of blood on CT and the risk of vasospasm. The modified Fisher scale ranges from 0 to 4. When there is a focal or diffuse thin subarachnoid hemorrhage without intraventricular hemorrhage, the risk of symptomatic vasospasm is 24%. When there is a focal or diffuse thin subarachnoid hemorrhage with intraventricular extension, the risk is same with when there is a focal and or diffuse thick subarachnoid hemorrhage without intraventricular extension, where the risk is 33%. And for focal or diffuse thick subarachnoid hemorrhage with thick intraventricular hemorrhage, the risk is 40%. For endothelial dysfunction, the blood breakdown products disrupts the endothelial nitric oxide synthase. This nitric oxide synthase that is being reduced reduces the nitric oxide availability. Nitric oxide is a potent vasorelaxant. So with this disruption, there is a reduction in vasodilatation. So the hemoglobin also scavenges this nitric oxide. And there are theories that decrease production of nitrous oxide and prostacyclin, which are vasodilators or vasorelaxants, with overproduction of endothelin 1, account for the cerebral vasospasm. The barrier that is compromised also leads to has been noted.
Hello, Dr. Bright, we can't hear you. Hello, Dr. Aka, because I can see you are with us. Your mic is muted. We can't hear Dr. Bright. We can't see any slide presentation. So maybe you need to change your network or something, because your connection is poor.
Okay, maybe you can project for me.
Well, we can see your slide now. Can see your screen is visible. You just need to enlarge it and put it on slideshow. So just to say that you have about 8 minutes left. So if there's a way you can manage your time.
Okay, I will. Okay, the oxidation and the inflammation and oxidative stress. With these damaged vessels, there is activation of leukocytes, microglia, and complements and there is production of cytokines, such as interleukin-1, interleukin-6, monocyte chemoattractants, protein-1, tumor necrosis factor alpha. These and the reactive oxygen species have a way of activating the inflammatory process. Then the activated macrophages has a way of activating the JAK2, STAT3, and nuclear factor kappa B, which perpetuate further inflammation. Then the matrix metalloproteinases further contribute to the vasospasm. The P-selectin and E-selectins have also been found to be upregulated in patients with ruptured aneurysm, and the patients with clinical vasospasm have also been found to be in a more coagulable state when compared to those without delayed cerebral ischemia or clinical vasospasm. This is a pictorial representation of the inflammatory and oxidative processes. Then for the oxidative process, in addition to it, with the breakdown products, methemoglobin, the superoxide is available, and the superoxide dismutase has a way of invoking the process of dismutation such that the superoxides are converted to hydrogen peroxide and water. But for those that escape this, they cause further macromolecular damage, and irreversible results are noted. Smooth muscle contraction is another important factor in this pathology, because there is impaired vasodilatory mediators and there's overactive vasoconstrictive mediators, and both can also be seen. There is increase in intracellular calcium in the vascular smooth muscle. This calcium binds to calmodulin, and the calcium binding to calmodulin activates the myosin light chain kinase. This leads to phosphorylation of myosin. Then cross bridges are formed between the myosin and actin, leading to contraction. While myosin light chain kinase causes phosphorylation, myosin light chain phosphatase causes dephosphorylation, but ureokinase pathway inhibits the myosin light chain phosphatase pathway. Hence, it keeps the myosin phosphorylated, and there is sustained contraction even without a high volume of calcium. The diagram shows the pathway where calcium calmodulin binds to the myosin light chain kinase, and this further buttresses the receptors, which can be voltage gated or receptor gated. Then vascular remodeling can occur. This vascular remodeling from increased proliferation of smooth muscle and intimal hyperplasia, further narrowing the vessel lumen. And the P-selectin, D-selectin also have a way of adding to this morphology as seen. So the effects of this are persistent vasoconstriction, smooth muscle, persistent vasoconstriction of the smooth muscle, reduction in vessel diameter, reduction in cerebral blood flow, ischemia. Then correlated findings, patients with higher risk, the risk of cerebral vasospasm is found in conditions where arterial blood at high pressure contacts the vessels at the base of the brain. When the blood clots are especially noted to be spasmogenic, when they have a direct effect when they contact the proximal 9 cm of the anterior cerebral artery and the middle cerebral artery. Patients with Hunt and Hess grade on admission correlates with their risk of cerebral vasospasm. Higher incidence is noted with increasing age. Cigarette smoking is an independent risk factor, and history of pre-existing hypertension has been noted. Angiographic dye has also been found to exacerbate cerebral vasospasm. An antifibrinolytic agent, though reduces bleeding, increases the risk of vasospasm. Hypovolemia also increases the risk of vasospasm. These correlated findings are taken into consideration in the management of the patient. I'll hand over to my colleague for the presentation and management. Thank you.
Thank you, Dr. Bright. Yeah, so before you go ahead, Dr. Aka, just want to quickly acknowledge the presence of one of our teachers. So we have with us Professor Komolafe. You're welcome. You're welcome, sir. I also want to acknowledge the presence of some of our senior faculties here also, including Dr. Linda, Dr. Aniaku, and Dr. Undukuba. I apologize if I missed out anyone, but all other faculties are also welcome to the meeting. We listened to Dr. Bright on the physiology and pathology of cerebral vasospasm as giving a lucid presentation. I apologize on their behalf. You know, we've had some connectivity issues. So, but going forward, hopefully it should be better. So we have next Dr. Aka to talk about the clinical presentation and management. But just to add that we can drop our questions in the chat box. They'll be entertained at the end of the presentation. Dr. Aka, so you have 25 minutes. But if you could, you know, deliver your talk in a shorter time, that would be appreciated. Thank you. Please carry on. Dr. Aka, your mic is muted.
Okay, sorry about that. Standing on the already existing protocol, I'll be taking the presentation and management of cerebral vasospasm. Usually, this condition typically commences after 3 days post-subarachnoid hemorrhage, and it's really not been seen earlier than that. Usually, the peaks are between the 6th to 8th day post the ictus, and it, though rarely, can occur at day 17. Usually, the period at risk is between the 3rd and the 14th day. So usually also the clinical resolution occurs by the 12th day post-subarachnoid hemorrhage. However, radiologic resolution really takes longer, almost up to 4 weeks. The onset is usually insidious, but may be sudden and rapidly progressive. Some patients, some of these patients may present asymptomatic. In fact, patients can have radiologic vasospasm without clinical vasospasm. So patients who are conscious may present with focal symptoms or even generalized symptoms. And then these symptoms, and then patients may also be unconscious. For the localized finding, usually they may present with headache. And this headache may be a new onset headache. Maybe the patient was previously normal, maybe have been recovering from maybe the rupture of the subarachnoid hemorrhage, and then now begins to experience new onset headache or worsening headache, or maybe altered level of consciousness, disorientation, or meningismus. So these are non-localizing findings. Now, for the localizing findings, usually may present with cranial nerve pulses, focal motor deficits, and may follow vascular territories. For instance, the anterior cerebral artery territory that would usually give us some frontal lobe manifestations like abulia, urinary incontinence, and drowsiness, and some slowness and delayed responses. Then the middle cerebral artery territory may give us contralateral hemiparesis, monoparesis, aphasia, and while the posterior cerebral artery territory may give us some visual disturbances, and then the vertebral areas may give us the cranial nerve deficits that we have been noted. So approach to diagnosis would really be a patient that presents with these new onset headaches. You will be to suspect and then rule out other differentials that may present similarly with this cerebral vasospasm. And this will include rebleeding, hydrocephalus, cerebral edema, seizure, dyselectrolytemia, and hypoxia with sepsis. So approach would be to rule out this, as this may mimic cerebral vasospasm. Now, investigation of choice would be the digital subtraction angiography. Now, this is the gold standard and will typically demonstrate this vasospasm, that's the narrowing of the vessel, as seen in this image. So, but this is, we know, is really invasive, and one investigation that also mirrors this DSA is the CTA. It has almost similar sensitivity and specificity with DSA, though that's the CT angiogram, and then this combined with CT perfusion studies would also demonstrate the area of vasospasm. So on my left, this is a CTA showing a CTA image showing the area of narrowing around the middle cerebral artery, as shown in this picture. That's M1, that's our arrow as demonstrated in this CTA. So other studies like the transcranial Doppler, which is really non-invasive, can also be used to also predict and determine if this patient is having cerebral vasospasm. So values that are less than 120 centimeters per second for middle cerebral artery velocity is normal, and then those between 120 to 200 are considered mild, and then greater than 200 cm per second are considered severe. Now, this is usually done in such a way that the narrowing at the MCA compared to ICA is assessed in the Lindigard ratio, such that usually when it is less than 3 is normal, and 3 to 6 mild vasospasm, and greater than 6 is considered severe vasospasm. So this image also demonstrates the CT perfusion studies, which we've mentioned. This area that is marked shows area of reduced perfusion. So what is actually considered here is the mean transit time of the blood, and then the cerebral blood flow, and then cerebral blood volume. So usually this gives us an idea of what is going on with respect to ischemia. Now the ischemia now gives us an impression that there's been a cerebral vasospasm, narrowing of the vessel, supplying that area. So this is an image showing the transcranial Doppler for each one. So each vessel that is considered is now assessed using the TCD to determine the velocity of flow. And then this is a picture that shows patient being assessed for that. So these are all imaging studies too. So the MRI is also important in these patients, especially the diffusion-weighted MRI image sequence, which shows the area of a restricted diffusion and then confirmed on the ADC map, as seen beside. And then MRA may also be important, especially the time of flight sequence, and then the contrast enhanced MRA can also help us in determining this condition. So when the diagnosis is made, usually the treatment strategy would involve a multidisciplinary approach. Now will involve the neurosurgeons, the interventional radiologists, will involve the nurses, and then other members, even the neurophysiologists, who may have to insert an ICP monitor to help in managing these patients. And then the goal will be to prevent this cerebral vasospasm, because it can be a life-threatening condition. So the aim will be to prevent it, and then where it occurs, to treat it, and then monitor this patient closely. Then there are different modalities of treatment, which have been broadly divided into medical and surgical. Now, there's been no established effective method in preventing that actually prevents this vasospasm from occurring. Although there are medications that have been tried, and also some interventions have been tried to improve, to try to prevent it from occurring, and then to improve outcomes following this condition. And then the goal will be to avoid anemia, hypovolemia, and then avoid prophylactic hyperdynamic therapy. Now, this used to be the goal. This used to be the in thing traditionally, but there's been a shift from use of hyperdynamic therapy and hypervolemia and also use of the hemodilution. That's the popular triple therapy. So there's been a shift to modifications of this into hypertensive therapies to be able to achieve that. Now, the aim is to clip and coil early. Now, when this is done, one can now approach it through the hypertensive therapy. Well, if hypertension is induced, it may even lead to rupture on unsecured aneurysms. So there are general measures that are usually adopted, and these general measures include use of bed rest, 30-degree setup, mechanical anti-DVT, and then monitoring of input-output, because these patients may present with this electrolytemia and also even dilutional hyponatremia. So this patient needs to be monitored closely. And for the preventive measures, there's the use of nimodipine. Nimodipine is a calcium channel blocker, and it's been found to improve, to reduce mortality up to 80% in patients. That's the evidence from a randomized controlled trial that was done sometime in 1988. Then also, use of oxygen therapy is quite important to improve the partial pressure of oxygen to keep it greater than 70 meters of mercury to ensure hypovolemia. Hypovolemia is common, and this may be as a result of cerebral salt wasting, and these patients also would need the hematocrit needs to be kept between 9 to 10. The hemoglobin needs to be kept between 9 to 10 grams per day to encourage perfusion. And then colloids may also be used in this patient. Now, mannitol should be used with caution, even though it's been shown to improve the rheology of blood. One should be wary of hypovolemia since it's an unwanted situation. Now, actually, should be inserted to monitor BP. We know that even though the BP would improve perfusion, it might also lead to rupture or rebleed in an unsecured aneurysm. The pulmonary artery catheter should also be inserted to monitor the pulmonary wedge capillary pressure and then cardiac output when possible. Central line to monitor CVP, which should be kept between 8 to 12 millimeters of mercury. And then to insert ICP monitor where it's felt to be problematic. Now, it's important to also monitor these patients' arterial blood gases, the hemoglobin concentration, hematocrit, and chest X-ray, because some of these patients may have a pulmonary edema and cardiac strain. So serum electrolyte and creatinine should be monitored, and osmolality should be monitored 12 hourly, and then the patient should be on ECG monitor because of the risk of cardiac failure. So once the aneurysm is actually treated, initiating therapy before the vasospasm is apparent may minimize mobility from it. Intravenous fluid are usually employed to maintain euvolemia, while vasopressors are used to increase systolic blood pressure. Usually, once the aneurysm is secured, one can target the BP to be between 140 to 220 millimeters of mercury to improve neurology. Now, there are also other surgical treatments that can be employed. Now, these surgical treatments are usually employed in situations where preventive measures are not working, or the euvolemic therapy that has been employed where it is not able to address the patient's concerns. And then these surgical methods have been divided into the direct surgical methods and then the indirect surgical methods. Now, the use of angioplasty, there are two broad types of these angioplasty that are used to improve the dilatation of this narrowed vessels. Now, there's use of the stent angioplasty and the use of balloon angioplasty. The balloon angioplasty usually favors proximal vasoconstrictions, and while the stent angioplasty usually favors both proximal and distal vasospasm. So this image on my right shows areas where this may occur, and then typically the proximal segments of the middle cerebral, the M1, and then ICA, basilar vertebrae are typically areas where that are amenable to transluminal balloon angioplasty. And the uncommon areas, the PCOM area, P1, A1, M2 branches, and these are areas that are not quite common. So that are amenable to balloon angioplasty. So while this angioplasty is done, it can also be combined with intraarterial injection of drugs like nicardipine, papaverine, even nimodipine, and nitroglycerin can also be injected, and verapamil can also be injected during these procedures. Why this balloon angioplasty can be done in combination, and then even the combination therapy have been found to improve outcomes. Now, indirect methods of trying to correct or treat this cerebral vasospasm include clipping and coiling. Now, this is important in the sense that it enables one to now to facilitate hypertensive therapy. And then during the process of clipping, the spasmogenes, which my colleague talked about earlier, can also be irrigated and copiously irrigated and washed off from the area where they cause the vasospasm. And then some thrombolytic agents can also be done. And then CSF drainage is important because it's been shown to also improve the removal of these spasmogenes. Now, this is a picture that shows the balloon angioplasty, where after coiling, and this is done to actually improve the caliber of the vessel. And then this is this is actually the Comanensi device that one of the devices have been used for stent angioplasty. So this image shows area of a vasospasm before treatment, before injection with intraarterial drug, and then following injection. Now, the challenge with this intraarterial injection is that it's sometimes one may need to inject several times, and it may lead to, because of recurrence. What are the complications? Complications are shared with this condition. Now, these complications include the hemodynamic augmentation that is done for this patient can be complicated by exacerbation of cerebral edema and increase in ICP, hemorrhagic conversion of ischemic infarcts, pulmonary edema that is seen in 17% of patients, rebleed, and then some of the complications associated with pulmonary arterial catheter as listed below. Now, for the prognosis, positive factors that improve outcome include early detection, and then where this vasospasm is quite mild, that's using the Lindigard index of 3 to 6, and then preservation of cerebral vasospasm, and then absence of microthrombosis on advanced neuroimaging. Then some of the negative factors include severe forms of vasospasm, then patients have developed delayed cerebral ischemia, and then presence of multiple pathologic mechanisms, that's those having vasospasm in addition to microthrombosis, and then those that have posterior circulation involvement. Some of the agents that have also been tried that have also improved outcome include use of milrinone, which is a phosphodiesterase antagonist, which has been shown to improve outcome. This can be given both intravenously and also intraarterially to improve vasospasm. Then the clazocetan, which is an endothelin, that's the ETA endothelin 1 receptor antagonist, which my colleague described in the pathophysiology. This can also improve the patient's that's the vasospasm and improve outcomes. Then combination therapies can be used. Now, there's a drug that is called the Fasudil, which is quite common in Japan. That drug is actually a Rho kinase inhibitor, which my colleague also talked about in his pathophysiology as one of the mechanisms that leads to vasospasm. So this has also been shown to improve outcome, even though it's not widely used. Now, in conclusion, this condition can actually go unnoticed, and it can, because it can mimic patients that have maybe seizures, patients that have rebleed, hydrocephalus, cerebral edema. It's important to have a high index of suspicion. And this usually from the 3rd day, since it starts on the 3rd day, when there's a new symptom, it's important to suspect and then detect it early through and confirm with neuroimaging, and then timely intervention to improve outcomes. Thank you. for listening. These are my references.
Thanks for your time. We'll leave you now. Donald Trump, I'm afraid, has.
Yeah, thank you, Dr. Thank you, Dr. Bright. So we thank the presenters for this, Dr. Bright and Dr. Aka. At this point, we're going to entertain questions and have answers to those questions. And then, if you like, also just a comment if that's the case. So questions, comments from the house. I can see that the chat box is empty. So you can indicate by a raise of hand for recognition. So it's commonly said that if you have a presentation done and at the end you seem to have a lack of questions, and it's either it's been well delivered or there have been some commas along the way, so to say. But I want to believe they've done some justice to this topic. Yes, so we have Dr. Larry, please go ahead. You can unmute and speak. Your mic is muted.
Hello, can you hear me, sir?
Yes, we can hear you clearly.
Good evening, everybody, senior colleagues and colleagues. I want to say thank you so much for the to the presenter for the well elucidated and delivered presentation. I want to add that I don't know because I was disconnected in some part of the presentation why the management was being presented, that magnesium sulfate is also part of the vasodilator that has been in use for this condition. And also one of the surgical treatments for it is sympathectomy to dilate the vessels. Now, I want to ask, just thinking aloud, and in a bit where patient had a traumatic brain injury and the subarachnoid layer is breached with bleeding into the brain parenchyma, or even surgical patient, can we extrapolate these treatments into and them? Can it reduce morbidity and mortality due to vasospasm in this patient, considering that the central point in the pathophysiology is the presence of blood product and other implicating ions in the subarachnoid tissue. So can this be used to prevent more morbidity or mortality in patients that had brain surgery or traumatic brain injury with a blood splash into the subarachnoid tissue? Thank you.
Thank you, Dr. Larry. An interesting one. So I think this is direct. This is for Dr. Aka. Your response, please.
I would like to appreciate the last commenter, the person that commented on the presentation and the question he asked. Regarding magnesium sulfate, yes, I've noted your comments. However, I would like to just add that MASH study that was carried out actually did show that magnesium sulfate has not been proven to be of clinical benefit in patients that have cerebral vasospasm. For the sympathectomy, I've taken note of that. Then for the traumatic patients, I have traumatic brain injury, and then surgical patients. Yes, if there is clinical evidence of cerebral vasospasm, which is the one that is oftentimes pursued, these measures can be put in place. And then when it is confirmed on radiology, the same approach that has been used to manage these patients can be employed. However, we usually don't typically prophylactically give patients that have traumatic brain injury nimodipine, and then those have had just surgery, nimodipine. But I do believe that once there is clinical evidence of vasospasm, and which is confirmed on radiology, these measures would also come into play. Thank you.
Thank you, Dr. Aka. Yeah, we have well, essentially a comment in the chat box thanking the presenters. Yeah. So, any other question? Okay. I guess in the absence of any other question, we'll move on to listen to our guest faculty for today. You know, as they say in Nigeria, an adult or rather an elderly person sits down and sees afar, and a little child climbs a tree but cannot even see, you know, beyond his nose. So we have one of our teachers with us today, who will share with us his some insights into this subject matter, and of course, possibly practical experiences as far as this is concerned. We have with us Professor Femi Bankole. He's a distinguished consultant, neurosurgeon and head of neurosurgery at Lagos University Teaching Hospital. He graduated from OAU, Obafemi Awolowo University Hospital, and became a fellow of the West African College of Surgeons in 2002. And since then, he has been at the forefront of neurosurgical care, training, and advocacy in Nigeria and West Africa. He has undergone further specialty training at globally renowned institutions, including the Emory Clinic in Atlanta, the Mayo Clinic in Rochester, and the Care Hospital in Bali. Professor Bankole holds an academic appointment at the Department of Surgery, College of Medicine, University of Lagos, where he currently serves as professor and head of neurosurgery. He's a trailblazer in expanding access to high-quality neurosurgical services. He has trained numerous neurosurgeons who are practicing in the country and internationally. He has also participated in medical missions throughout Africa and Southeast Asia, and is an avid mentor of young professionals in and outside medicine. His professional mission remains clear, which is to elevate the standard and reach of neurosurgical care throughout Nigeria and the sub-region. So I'm highly honored to have him. And Professor, you're welcome, sir. I yield the floor to you, sir.
Okay. Can you hear me?
Yes, we can. I just need to mute some participants. But we can hear you, sir. Please go on, sir. Professor, your mic is muted.
Oh, sorry about that. Can you hear me?
Yes, we can hear you clearly, sir.
Okay. All right. So thank you to the presenters. I'm in the middle of a procedure, but I just stepped out to do this. But I've been paying attention to what has been said. So thank the presenters for taking us through the basic pathophysiology and also the clinical presentation. So taking off from the last from the question. So typically, symptomatic vasospasm, cerebral vasospasm, most of the time, at least we tend to think it occurs more in the setting of aneurysm or subarachnoid hemorrhage. But it is true that with some trauma that's expensive, patients may also develop vasospasm, and that may account for deterioration in their clinical status that is unexplained by imaging in terms of no hematoma, and they're wondering why they're not waking up as much as we think that they should. So the treatment as have been outlined, I think the only sort of new thing, I mean, nimodipine is the go-to typically orally. Nowadays, there's intra-arterial formulations of nimodipine and intravenous formulations that are being tested, but they are not widely available. I don't think we have them in country. In that intra-arterial one is sometimes used if one is trying to resolve the vasospasm endovascularly. But intravenously, some people have developed it to try and improve on, because obviously oral nimodipine is an old formulation, and the issue of whether intravenous formulations will be better is there. But apart from nimodipine and the other magnesium sulfate that we mentioned, papaverine is also available, but it's neurotoxic, so it's typically applied locally. We do that sometimes when we're operating in heart surgery, then we sort of bathe the vessel with papaverine to improve on the vasospasm. I think the other thing to say is the fact that the relevance or the importance of cerebral vasospasm many times is not properly highlighted or identified during the course of the patient's clinical condition. So just this kind of topic helps to awaken our senses to that. There are some tests, I think that was mentioned, transcranial Doppler, which we can do because most places have ultrasound, but I'm sure very few people deploy it. I know we don't deploy it in our center, but it's probably something that we should start to deploy to try and determine to detect early if vasospasm is occurring, and then we can then treat it using the methods that have already been highlighted. By and large, it remains a challenge, but every effort should be made to prevent it, to detect it early, and also obviously to treat it promptly if and when it occurs. So I will sort of leave it at that. And if there are any other further questions or areas of clarification, then I will be happy to answer those questions. Thank you.
Thank you, sir. Thank you very much, sir, for this succinct talk, sir. We really appreciate it. Thank you for sharing with us from your deep wealth of knowledge.
Yeah. I apologize. I had some slides, but like I said, I'm not in a position to share them. But I think basically that's covered most of what I have to say. Apart from taking us through some of the guidelines from the American Heart Association. I think that's basically what it says.
Yes, sir. Thank you very much, sir. We really appreciate all you've told us. They are really helpful insights. Thank you very much, sir. Yeah, so we would like to entertain a question, or rather comments, actually, from any of our teachers here. Professor Komalefe, sir, please permit me to call on you to maybe add one or 2 points that would be of help to us as young neurosurgeons, trainers, and trainees, as it were.
No, sorry, this is not Professor Komalafe, Professor Mrs. Komalafe.
Oh, my apologies, man. Well, we're happy you are with us, man.
Thank you.
Yes, man. Thank you very much. Yeah, so at this point, I think we've, well, I would say my task is completed. So I'll quickly, I just want to thank the presenters again and the center from which, the center they represent. We thank them very much for the job done. And I'm sure we've all learned one or two things, and we'll keep learning. So I'll at this point hand over to Dr. Guga, the head of the YNNF group. Dr. Guga, sir.
Thank you very much, Dr. Nauro. Very well done. I think Dr. Deboe is a co-anchor, but you called me, so it's fine. Big thank you to our presenters for the day, Drs. Bright and Aka, as well as to you, Dr. Nauro, for moderating so excellently. We appreciate our senior faculty, Professor Bankole, who is our NANS president, our father. We thank you so much, sir, for the support that you give us, the young ones, and we appreciate your insight on this important topic. Thank you to Dr. Adegboye for keeping this going, the coordinator of the webinars committee. We appreciate you. And we appreciate Professor Mrs. Komalafe, the NSNS president. Thank you, Ma. We appreciate you for coming, and we're encouraged by your presence. Thank you to every other senior faculty who came in, both those who've been recognized and those whose name we couldn't identify. We thank you. And indeed to every member associate of the YNNF. We'll keep this going with another interesting topic next month, God willing. Have a very beautiful weekend ahead. Bye for now.